Hello, do you guys hear me?
Yes, we
Yes.
can.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Thank you, Dr. Alwi. Thank you, everyone, for coming. Welcome to Endocrinology Seminar. Today, inshallah, we learn about childhood diabetes mellitus, panhypopituitarism, hyper and hypothyroidism, and rickets. My name is Wan Amina Dira, and I'll be sharing about childhood diabetes mellitus. So, what I will cover today: physiology, pathophysiology, etiology, clinical characteristics, complications, investigations, and treatment. Next. So what is childhood diabetes mellitus? Diabetes mellitus is a chronic disease involving glucose regulation abnormality, which usually involve insulin and glucagons. Both of these hormones are responsible in this glucose regulation. Insulin is produced by the beta cells in the center of islets of Langerhans, and glucagon is produced by the alpha cells in the periphery of the islet of Langerhans. Usually, I remember by beta kat tengah. So beta cells, insulin, we remember insulin more than glucagon, right? So beta is more dominant. So beta cells produce insulin at the center. Next, for the insulin, Atira, next. Next slide. For the insulin, the physiology, insulin is responsible to lower the blood glucose. When we eat, after a meal, the blood glucose level will increase. So this insulin will be secreted, and this insulin will bind to the insulin receptor of the cell membrane of the muscle cells or adipose tissue. And when the insulin receptor is bind to the insulin, this will send signal to the glucose transporter, and then this glucose transporter will transport glucose into the cells. This one is for insulin. And then for the glucagon, next. For the glucagon does exactly the opposite of insulin. Glucagon will increase the blood glucose level. How? Glucagon will trigger the liver to break down the glycogen into the glucose, and also to produce glucose from other sources in the body. Thus, it will increase the blood glucose level. And then for the classification, generally in diabetic patient population, 90% of them is having the type 2 diabetes mellitus. But in children, diabetes mellitus type 1 is the most common one. Diabetes mellitus type 1 is when the body does not produce insulin. But for diabetes mellitus type 2 is when the body does not respond to insulin. Differentiating both diabetes mellitus type 1 from diabetes mellitus type 2 can be quite challenging on the clinical characteristic, because they both present with quite similar symptoms. But then, okay, let's see. For clinical characteristic, they both have polyphagia. This is because when the cells does not when the body does not produce insulin, the cell will not receive glucose, so the cell will not have any energy. This will trigger the body to eat more, so the patient will become polyphagia. Poly means a lot, phagia means eating. And then for polyuria and glycosuria, this will happen when the blood glucose level is high. The glucose concentration of the blood will exceed the renal threshold. Like we know, the blood will flow into the renal, right? And then when this glucose exceed the renal threshold, the glucose will present in the urine. And as glucose is osmotically active, it will attract the water together with the glucose. Then it will lead to polyuria at the same time. And then for polydipsia, when a person urinate a lot, he or she the body will try to compensate the water loss by stimulate thirst. So the person will have a polydipsia, which is poly means a lot, dipsia means thirst. And then for peripheral neuropathy and retinopathy, this is due to the prolonged high blood glucose concentration that will impair the nerve function. Next, but then the most obvious difference between these two types of diabetes is the pathophysiology. Let us first look at the M type 1. For the M type 1, there is autoimmune destruction of the pancreatic beta cells, right? So, there is a genetic abnormality whereby the HLA system is involved. The HLA linked genetic predisposition, which are usually HLA-DR3 and HLA-DR4, are usually involved. Because but then not everyone with this HLA will get the M type 1. Only those with the genetic abnormality. When this HLA system is actually responsible for to recognize foreign body and also to modulate self-tolerance. But then when there is abnormality in this gene, the T cells will lose its self-tolerance and it cannot recognize its own body cells anymore. And it will lead to type 4 hypersensitivity, which is a cell-mediated immune response. The T cells will attack the beta cells and then the beta cells will inject, no insulin will be produced and type 1 diabetes mellitus will occur. When the this beta cells destruction usually will occur early on life, but then the symptoms will only appear when the pancreas is 90% damaged. Next, for the complication, diabetic ketoacidosis is common among diabetes mellitus type 1 because there is absolute insulin deficiency. When there is no insulin at all, the body will try to get energy from the last source that we can get, which is the lipid. So the lipid will be lysed. There is increased lipolysis, and then there will be increased free fatty acid release. The free fatty acid will be oxidized and lead to ketogenesis. Ketogenesis is the production of the ketone bodies. For example, like acetoacetate or beta hydroxybutyrate. Actually, both of these ketone bodies important for the cells to get energy, but then at the same time it will increase the acidity of the blood, so it will lead to diabetic ketoacidosis. When there is DKA, the patient may present with vomiting due to increased acidity, and at the same time, due to the vomiting, he or she will have abdominal pain. And then Kussmaul respiration, the patient may develop Kussmaul respiration, which is deep breathing, because the body try to compensate the acidity by trying to expel excess carbon dioxide through respiration. All of this acidity can be reversed by giving fluid, insulin, and electrolytes. Fluid is given to restore the dehydration, insulin to lower the blood glucose, and also electrolyte to balance the electrolyte imbalance. But this is a simple one. If you want to know the details of it, you can refer to pediatrics protocol. There is an algorithm about how to manage DKA specifically. Okay, by definition, when we say acidosis, of course, the H plus ion, the protons will increase in that, right? So there will be increase in hydrogen ion. But when the hydrogen ion is high in blood, the hydrogen ion will enter the cells. And then when it enters the cells, the K plus, the potassium, will exchange with the hydrogen ion, and potassium will enter the blood. So the potassium will be high, it will lead to hyperkalemia, and also low phosphate and low sodium. Despite the misconception, we usually heard that diabetes mellitus type 1 DKA, but actually diabetes mellitus type 2 also can have DKA. Okay, let's proceed with pathophysiology of DM type 2. So diabetes mellitus type 2 is when the body does not respond to insulin. The insulin is there, but not sufficient to trigger the response. As you can see there is insulin resistance in the M type 2. The green one is insulin and the purple one is glucose. The insulin is there quite a lot, but then it does not attract or apa, the glucose cannot enter the body cells because of the insulin resistance. The organs are unresponsive to insulin. And then the risk factor for this DM type 2 is because of obesity and lack of exercise. The theory behind this is because of the excess free fatty acid. Free fatty acid will produce adipokines. These adipokines will cause inflammation to the insulin receptor and then further cause insulin resistance. But then not all obese people will have DM type 2. So family history or genetic relation also play a major role. And then actually DM type 2 is not really common among children. It is once rare, but it has been increasing lately in parallel with the increasing cases of childhood obesity. And then next one, the complication for DM type 2. When we say DM type 2, it is different from DM type 1 because DM type 1 is absolute insulin deficiency. But for DM type 2, it still have insulin but in small amount compared to other normal humans. So DM type 2, it still can prevent from DKA to occur. When there is a relative insulin deficiency, the body will increase proteolysis in order to increase the gluconeogenesis, production of new glucose. And then it will lower the glucose utilization and also increase glycogenolysis to produce more glucose. So all of this will result in hyperglycemia, which is high blood glucose concentration. When there is hyperglycemia, glucose is a solute. So when it is a solute, the glucose is high in blood, it will attract the water, it will draw the water out of the body cells into the blood vessels. So when the water out of the cells, the body cells will be left relatively dry. And then there will be a lot of fluid in the blood and lead to glycosuria and polyuria. And at the end, resulting in hyperosmolar hyperglycemic state. Hyperosmolar hyperglycemic state is due to the high glucose concentration that cause high osmolarity and high glucose in blood. Next, complication. Okay, for the investigation, a diagnosis of diabetes mellitus is made based on these 4 glucose abnormalities together with other diabetic symptoms. Like adults, we use fasting glucose, random glucose, OGTT, HbA1c. Fasting glucose more than 7, random more than 11.1, OGTT more than 11.1, HbA1c more than 6.5. For HbA1c, we can measure the HbA1c because the excess glucose actually bind to the glycated hemoglobin, and it is not just it will reflect 2 or 3 months before the glycemic control. It reflects the glycemic control 2 or 3 months before. But HbA1c, we cannot rely on its own, because let's say if the patient is having HbA1c less than 6.5, that does not rule out any possibility of having diabetes. We still need to consider diabetes with other investigation. And also we can do autoantibodies testing, because as we know in DM type 1 there is autoantibodies attack the pancreatic beta cells, right? So we can check for the anti-islet antibodies, insulin autoantibodies, and then C-peptide and insulin levels. Let's recall on how insulin is synthesized. It is synthesized from B cells, and then first it will produce proinsulin, right? And then proinsulin will be cleaved into insulin and C-peptide first. And then C-peptide, C-peptide have longer half-life than insulin. So we can measure the C-peptide in reflection of the insulin. It is more accurate test of islet cell functions. That's all. And then for the treatments, all children with type 1 diabetes mellitus will need insulin as their treatment regimen. And then for type 2 diabetes, they can practice weight loss, exercise, healthy diet, anti-diabetic medication such as metformin. And metformin is the only medication or hypoglycemic agent that is allowed by FDA for the children. And then if none of the above interventions are effective, so the patient can opt for insulin. Talking about insulin, every individuals need a different amount of insulin, and it changes over time. The correct dosage of insulin is the dose that can achieve the best glycemic control with less obvious hypoglycemic events. Because when the patient take insulin, when the patient take insulin and he or she does not take meal properly or take the insulin properly, it can lead to hypoglycemia. The symptoms can be weakness, hunger, shaking. These are only mild symptoms. So it can be treated by giving sweets and juices. But then for more severe cases, such as loss of consciousness or seizures, they can give IV glucose immediately to treat the DM. And then next, this one as summary. So differences, type 1, 6 months, or to young adulthood, type 2, usually puberty or later. And then clinical presentation, most often acute for type 1, and for type 2, variable, often insidious. And then for autoimmunity, like I said before, type 1 present, and then type 2, no autoimmunity. And ketosis, type 1 common, type 2 rare, but it is not, it's still possible, but it is rare. Usually we relate type 2 with HHS, hyperosmolarity hyperglycemic state, and then body habitus usually lean for type 1 and often overweight or obese for type 2. And then for insulin deficiency, like I said before, type 1 is absolute and type 2 is relative. Next, these are the references. That's all. Thank you.
Thanks, Sergam. Good presentation. So, any questions? Anyone? Anyone? Any questions? Any questions? Anyone? Tak ada. Okay, this is a very important topic. Diabetes is very important. It's very common. It's relatively common. It's not very common. It's relatively common. About 70% of children have type 1 DM. But bear in mind, the prevalence of type 2 DM is increasing. Kejap Wise. Makan Wise. So type 2 DM is increasing. And we are seeing younger and younger people with type 2 DM. Wait. Okay, actually, the when we talk about DM kan in pediatric, in children, there are new ways to classify DM rather than type 1, type 2, which is it's not mutually exclusive, no inclusive, which means there's a lot of other type of DM, especially in pediatric. DM in pediatric is more dynamic, and there's a lot more of DM in pediatric rather than in adult. In adult, we do have type 1 in adult, okay, but usually these are actually just continue follow up from pediatric. So in pediatric, in general, diabetes nowadays we divide into two, okay? We divide into monogenic diabetes and polygenic diabetes. This is the more recent classification of diabetes. Monogenic diabetes are diabetes that actually resulted by a single gene defect, okay, following Mendelian inheritance. So basically, these are exact. So basically, this monogenic diabetes is diabetes that resulted from a single gene defect. Okay, contoh diabetes yang monogenic ni macam Down syndrome, congenital diabetes, MODY, apa, some adalah few others. Polygenic diabetes is like diabetes type 2, some diabetes type 1. Actually, majority diabetes type 1 is actually polygenic. Diabetes type 2 is definitely polygenic. So there's genetic factors and also environmental factors. And in fact, when you talk about genetic in type 2, there are a lot of diabetes. There's a lot of gene involved. Kejap sebelum banyak gangguan lah. Okay, there's a lot of gene involved. There's no like single gene that can be pointed to lah. So that's diabetes in pediatric. And when we talk about diabetes in pediatric, we talk about insulin, mainly insulin. The treatment is actually mainly insulin because there's not many OHA is actually that are licensed to be used in pediatric. So you guys done your IM kan, internal medicine ke tak pernah?
No.
Untuk oral hypoglycemic agent kan, nowadays you got I think at least 7 to 10 drugs untuk OHA kan. Metformin we use, last time dia sebut metformin glucoside. Now there's at least 7 up to 10. We've got GLP-1 inhibitor, we've got SLT2 agonist, macam-macam lah. Okay. But in pediatric, when we talk about OHA, we only got metformin lah. Metformin and glucoside. And glucoside is only licensed for Down syndrome, for congenital diabetes. Tapi for other diabetes, it's only metformin lah. Okay. Ada soalan? Ada soalan tak?
No.
Okay. For your level, it's very important to understand the physiology lah, especially cellular physiology, ketogenesis, gluconeogenesis, glycolysis, and also the cellular punya mechanism acidosis kan, how our body compensate with acidosis. These are very important to understand the pathophysiology of DKA, HSS. Tapi in fact HSS is very rare in pediatric. You won't see HSS in pediatric. So for pediatric point of view, just focus on DKA. Okay. Even type 1 DKA, type 1, type 2 diabetes in pediatric pun, most of them presented with DKA rather than HSS. Okay lah. So next, kita boleh sambung dengan next presentation. Next topic is
Panhypopituitarism.
Okay.
Yang ganti Cushing disease.
Okay, good. Okay, the reason why I changed the topic because actually I'm not sure who decide the topic from beginning, but I realized some of the topic are actually quite irrelevant for pediatric. Rather than we talk about Cushing disease, which is very rare, it's very rare, almost never occur in pediatric. Because when we talk about Cushing disease, we are talking about the peripheral Cushing caused by adenoma. caused by adenoma. Kan, so there's a lot more endocrine disease yang more common, especially things like panhypopit lah. Okay, I rasa boleh proceed with panhypopit. So I kan ada banyak sikit gangguan lah. So ada annoying punya budak kat sini, dua orang yang buat perangai dia tadi. Okay.
Wait, where is my control? Oh, okay. Do you see? Do you hear my voice?
Yes.
And you can see my screen.
Yep.
Okay, what is a panhypopit?
Yes.
Yes.
Okay, okay.
Yes.
Alhamdulillah. So you can see my screen. Okay, so inshallah I will begin the presentation. Okay, Bismillahirrahmanirrahim. We praise Allah Subhanahu wa Taala. We send blessing and salutation upon our Prophet Muhammad Sallallahu Alaihi Wasallam, his entire household, all of his companions. May Allah bless every single one of them, and may Allah bless every single one of us. Alhamdulillah. So, Assalamualaikum, and a very good evening to our respected Dr. Alwi, and the member of the floor. Alhamdulillah. So, inshallah, today I will be presenting about the panhypopituitarism, and inshallah, this slide is about 30 slides, and we have 8 subtopic in it. So, inshallah, we bear with it. Okay, so
Sorry Ashraf, you may want to if there's, I mean, because panhypopit ni banyak kan, there's a lot of hormone involved. You may focus few lah, especially focus on ADH, focus on growth hormone. These two lah mainly. The rest is not that important lah. Like so TRH so TSH lah. TSH, ADH dengan growth hormone punya problem. The rest tu macam just flip through macam tu lah.
okay. Thank you, Doctor. Okay, so we have 8 subtopic, which is the first one is normal pituitary, and second by definition, and the third one is epidemiology, and the fourth one is pathophysiology, the fifth one etiology, clinical characteristic, investigation, and the management. Okay, so first we proceed with the normal pituitary. We need to know the physiology, the anatomy, and the so on. Okay, so about the normal pituitary, as you can see that, okay, let me open my laser pointer first. Okay, so basically this is a the pituitary gland, and is located at the sella turcica, and it is beneath the hypothalamus. Pituitary gland, we have 2 compartments, which is the anterior and the posterior, and the anterior one is it originates from the Rathke portion, and the posterior is from the infundibulum. It descends from the third ventricle. So the one that the adrenal hypophysis or anterior pituitary is the glandular type, which is it can secrete, it can produce and secrete hormone, while the posterior pituitary is the secretory type, which it can't produce, but it can secrete that hormone that was produced by the neuron in the hypothalamus, which is the PVN and the SON, supraoptic nuclei and paraventricular nuclei. So, okay, in the relation, we can also see that pituitary gland, in front of it, we have optic chiasm. So there are a lot of clinical manifestation that can derive from the optic chiasm. This is because the location is very near. So you can see the blood supply. We have the superior, this is the superior hypophyseal artery. This is the inferior hypophyseal artery. So so the hypothalamus will, this nuclei will send the trophic hormone into this median eminence and go into the anterior pituitary and promote or stimulate the anterior pituitary to produce or secrete hormone. But PVN and supraoptic nuclei, it produce ADH, and ADH and oxytocin hormone, and it descend through this blood vessel and go to the posterior. You can see that this is a long axon, and the hormone will enter the blood circulatory here, which is ADH and oxytocin. Okay, so okay, next, this is the overview. Okay, next. Wait. Okay, next. Okay, so neurohypophysis, which is the posterior hypopituitary, it can secrete two hormone, which is the oxytocin and ADH, which is vasopressin. Oxytocin is significant in to stimulate the contraction of the smooth muscle in the breast, to promote the milk letdown reflex. It also promote the uterine contraction during labor. And for ADH, which is one of the vasopressin, ADH acts on the smooth muscle around the blood vessel to promote vasoconstriction and to increase the blood pressure. And it also have a significant role in control the water excretion in the urine. So it acts on the kidney to decrease the water excretion and to maintain the water retention. Okay, that is the two hormone for the neurohypophysis. And the second one is adenohypophysis. Okay, we have hormone. I think there are a lot. Basically, thyroid stimulating hormone, it stimulate thyroid to secrete thyroxine. Growth hormone is to promote body growth and stimulate the secretion of the IGF-1. And FSH and LH is from the gonadotropin. It stimulate the FSH stimulate the this is some mistake. FSH is for gonad to stimulate gonad. LH to causes ovulation and formation of the corpus luteum in the ovary, and it also stimulate production of estrogen and progesterone by the ovary, stimulate testosterone production by the testes. And the last two is prolactin, which is stimulate the milk secretion and production. And the last one is ACTH, adrenocorticotropin. It stimulate the production of glucocorticoid, which is the cortisol, and also androgen at the adrenal cortex. One of the androgen is the androgen. Okay, it also maintains size of the zona fasciculata and zona reticularis. Okay, that is the brief about the role of pituitary gland. Okay, next, which is okay. What is the meaning of the hypopituitarism? Hypo is the under, and pituitarism is related to the pituitary gland. So it's according to the Dorland dictionary, it said that diminution or cessation of function of the adenohypophysis due to various reasons. And what is meant by the panhypopituitarism is basically that pan which mean by all. So there is a generalized or particularly severe hypopituitarism which involves all of the hormone that is secreted by the pituitary gland. And it leads to the absence of the gonadal function, insufficiency of thyroid, and adrenal cortical function. So, okay, that is the epidemiology of the hypopituitarism. Hypopituitarism is listed as a rare disorder by the NIH, and it affected about 200,000 individuals in the United States. Internationally, as hypopituitarism has an estimated incidence of 4.2 cases per 100,000 per year, and an estimated prevalence of 45.5 cases per 100,000 without gender. Okay, so that is next we go to the pathophysiology. Pathophysiology of the hypopituitarism is simple. Okay, basically it is when the pituitary hormone production is impaired, and we know that pituitary gland secrete hormone that can stimulate other target organ to produce other hormone. So the hormone production by the target gland also impaired due to the tropic stimulus deficiency. Okay, so in normal condition, which is if the physiologic target hormone level is reduced, let me take one example as cortisol level. Okay, the cortisol level is reduced. So basically, the pituitary, the hypothalamus, we secrete CRH to stimulate the the pituitary gland, and the pituitary gland will secrete ACTH to stimulate adrenal to produce cortisol. So, but in the hypopituitarism, this response is absent or suboptimal or inappropriate due of many reasons. One of the reason is the due to the compression. The second reason is due to the hemorrhage, and the last one is due to the iatrogenic. Hemorrhage is ischemic. So there is a lot of reason that promote to hypopituitarism, and okay, which result in the progressive secondary failure of target gland, and the patient will present with low target hormone level accompanied by low or inappropriate normal level of corresponding trophic hormone. Okay, so this is the best the common etiology of hypopituitarism in children, which is the mnemonic is crash. Okay, the first one is craniopharyngioma. The second C is crash CHASH syndrome. The third one is CPHD, and the second one is for R is the due to radiotherapy, cranial radiation for CNS or non-CNS, or due to the late effect of oncology treatment. A is for acquired brain damage, including the neonatal encephalopathy. Neonatal encephalopathy, encephalon is brain, pathy is disease or disease of the brain. The next is SOD or septo-optic dysplasia. Septo-optic dysplasia is disorder of the early brain formation, and the fifth is the HPE, which is the holoprosencephaly. So we go one by one. So for in craniopharyngioma is a cancer, if I'm not mistaken, arise from the craniopharyngeal cleft, which developed from the fusion of the two primordial structure, radicular pouch and the infundibulum, and it happened during the 4th week of gestation. So to remember the characteristic of the craniopharyngioma, we can use the CSE as continuous study for exam. Okay, so 2C to S2E. Okay, so craniopharyngioma is a benign tumor situated at supracellular area. Okay, first 2C is it is calcified and cystic. The second 2S is slow growing and squamous. 2E is epithelial and extraaxial, which is outside of the brain. Okay, next is the CHASH syndrome. CHASH syndrome is the autosomal dominant. And there are a lot of characteristics of CHASH syndrome, which is the colobomatous malformation of the eye, the retinal coloboma, the most common. The next is heart anomaly, which is it can produce as tetralogy of Fallot. Okay, the tetralogy of Fallot, the 4 characteristic is the first one is the override of the aorta. The second one is ventricular septal defect. The third one is pulmonary stenosis, and the last one is the right ventricular hypertrophy. And the next is A, atresia of the choana. Atresia is the sempit like stenosis lah. Stenosis of the choana. Choana is the back of nasal aperture and is divided by the vomer. And the next is retardation, both cognitive and somatic, and it also can present as the genital anomalies, and it also have ear anomalies. We can see that the patient have ear aid. It also can produce deafness. That is CHASH syndrome. The next one is combined pituitary hormone deficiency. CPHD is the most mutation. The most mutation is the PROP1, which control the transcription factor that control other genes in the process of the pituitary development and cell type differentiation. Okay, that's finish for the C. The next one is radiotherapy. Radiotherapy, whether it is prophylactic or therapeutic radiation, frequently can lead to the abnormality in the hypothalamic pituitary axis. However, radiation does not affect the posterior pituitary, but only the anterior pituitary. So anterior pituitary hormone deficiency include by radiation are irreversible and progressive. Next is the acquired traumatic brain injury. Okay, traumatic brain injury also is now well recognized as a major cause of pituitary dysfunction. And one of the example is the encephalopathy, neonatal encephalopathy. Next is the septo-optic dysplasia. Septo-optic dysplasia is a heterogeneous disorder clinically with two or more of a classic triad, which is the first one is the hypoplasia of the optic nerve. The second one is hypoplasia of the pituitary gland with variable level of hypopituitarism. And the last one is the midline brain anomalies, which is the absence of the septum pellucidum and the corpus callosum. Okay, next is the prosencephaly, which result from the failure of prosencephalon to divide adequately into two halves, which usually happen at the third and fourth week gestation. It is the most common for brain malformation. And this is the mnemonic to remember what is the clinical manifestation of the holoprosencephaly, which is the first one is hypotonia, hypothalamic dysfunction, and the second one is pituitary deficiency, and the third one is epilepsy. The fourth one is feeding difficulties. Fifth one is uncoordinated oral sensory function, and the sixth one is spina bifida. Seventh one is eating slow, and the last one is developmental delay. It is concluded in HPE fuse. Okay, that's the mnemonic to remember the holoprosencephaly. Okay, holoprosencephaly is a disease when the forebrain of the fetus does not separate. Okay, so what is the clinical characteristic of the hypopituitarism? Okay, so this is the clinical characteristic that we can see from the patient. Okay, so for the hormonal deficiency, ACTH, it can cause the adrenal cortisol insufficiency, and if the TSH is deficient, it can cause hypothyroidism, which can present as the weight gain, bradycardia, bradypnea, and so on. And if the affected hormone is the gonadotropin from LH or FSH, the patient might have hypogonadism. And we can see if the neonate have hypopituitarism, it has a micropenis in male infant, which the measurement is lower than 2 cm. If the growth hormone is affected, the patient might come with FTT, failure to thrive, and short stature. And the last one is ADH, which can come with the polyuria and polydipsia, because the patient can retain the water in the body. And okay, there are other presenting features that may be associated with the underlying cause. For example, which patient with space occupying lesion, if the patient have the tumor at the pituitary gland, it can compress the optic chiasm and may present with the bitemporal hemianopia. Okay, this is the details of possible finding on hypopituitarism examination, which is there are a lot actually. It go from the general inspection and go through the systemic review. And I think you can read. Okay, I just read. So if the patient came with this morphic feature, it might have CHARGE and HPE. If the body habitus inucoid is the type of body which usually the patient with inucoid body habitus, the patient might we call as galah in Malay, which the patient is tall, have long arm and long leg, and if the patient have diagnostic phases, maybe due to HPE or CHARGE. Okay, so I think that we can go this possible finding later. And okay, basically there is general inspection, and next is measurement. In measurement, if the height is short stature, it may due to hypothyroidism, GH deficiency. And if normal stature is due to adequately treated, maybe due to adequately treated hypopituitarism. US and LS ratio is the upper segment and lower segment. It increase in the hypothyroidism. Span is the when you extend your hand like this. If it is more than 4 cm more than your height, the height of the patient, If his arm span is 4 cm more than his height, it may indicate anechoic and unicoid habitus, which mentioned just now. H is the hypogonadism. Okay, sorry. Okay, next. Okay, this is examination of upper limb, which you can see the fingertips. The weight, if the weight if the decrease, it may due to malnutrition from the tumor brain injury. Okay, next is head circumference, increase in intracranial tumor, decrease in neonatal encephalopathy. So in upper limbs, we have head, we have eyes. Okay, coloboma we just mentioned just now in charge. Visual acuity, diminished SOD in septo optic deficiency. And in bitemporal visual field, bitemporal hemianopia in craniopharyngioma. Okay, this is the continuation. Examination for nose, for mouth and chin, for ears, for chest, abdomen, and gait and lower limbs. Okay, basically we can see that there is central cyanosis for tetralogy of Fallot. And okay, so yes, we can also see dysmorphic, which is one of the presentation of the CHARGE syndrome. And okay, so how do we investigate the hypopituitarism? Usually we investigate the hormone, the target hormone, and the trophic hormone itself. So we can use ACTH stimulation test to test for the ACTH. And next is growth hormone provocative testing hormone test, hormone release. And the third one is we can use TRF, thyrotropic releasing factor. And the fourth one, we can use the baseline, LH, FSH, testosterone, and estradiol. This baseline is usually we use when before the irradiation of the tumor. Usually when before we do irradiation of tumor, we of tumor at the pituitary gland, we make the scan for baseline LH, FSH. And if we see normal, and when the patient do the surgery or do the radiation to remove the tumor, the patient might present with the hypopituitarism, because as we mentioned, radiation can cause hypopituitarism. And the fifth one is we test for gonadotropin releasing hormone. And the sixth one is serum electrolyte, glucose, urea, and creatinine for diabetes insipidus, if I'm not mistaken. And the seventh one is simultaneous plasma and urinary osmolality. The eighth one is plasma ADH. The ninth one is water deprivation test, but rarely needed. And the 10th one is vasopressin stimulation test. And the last one is gene testing. Okay, gene testing is for congenital hypopituitarism, which mainly affect the gene, which is the first one is PIT1. PIT1 mutation in this gene, which is the pituitary specific transcription factor, which is responsible for the pituitary growth and hormone expression. And its mutation can lead to the CPHD1, CHPD1, which is the combined CPHD1, sorry, combined pituitary hormone deficiency. PROP1 is the prophet of the PIT1. Its mutation can lead to CPHD2, and neurohypophysin 2. Its mutation can lead to the neurohypophyseal diabetes insipidus. And we can also do the imaging, which is the X-ray of left wrist and hand for bone age. and it's very useful investigation to measure the growth of the child. And the second one is we need to use MRI if we suspect that the child might have the tumor in the brain. So for intracranial pathology such as craniopharyngioma, SOD, and HPE. Okay, next, this is the management. Usually for management of the hypopituitarism, we give hormone replacement therapy, and we need to remember usually we hypopituitarism, the sequence of the hormonal loss start from the FSH, gonadotropin first, gonadotropin, FSH, LH, and then followed by the growth hormone. And the next one is the thyroid hormone, and the last one to start to deficit is the cortisol hormone. So for management, for treatment, we need to manage the glucocorticoid first, which is the cortisol. Because if we not manage the cortisol first and we give the thyroid hormone, we give the thyroid hormone, it can induce the adrenal crisis because thyroid hormone can increase the metabolism of cortisol, and cortisol is very important in our body. So when the cortisol is deficient, it can it can cause adrenal crisis, which is the life-threatening. And next, we give the growth hormone if the patient has retardation, and we give the ADH replacement therapy if the patient have manifestation of the diabetes insipidus. And we also give the gonadotropin hormone replacement therapy needed in male infant with micropenis, and it also needed to induce the puberty in girls and boys. That is for the HRT. And the second management, if you can use the surgical approach, this is for tumor, and if the location of tumor is the intracellular tumor, we go through the transsphenoidal surgery, which is through the nose. And if the tumor is located at the supracellular tumor, we go through the extended transsphenoidal surgery. And if in the other location, we do the pterional craniotomy. Pterion is the location where the four bones meet, right? Squamous temporal, sphenoid, frontal, and parietal. I think that's all. This is my reference, and thank you for your attention. Inshallah.
Okay, good, very good presentation. Any questions from anyone? Any questions?
Doktor.
Oh, tanya ni lah. Tanya presenter.
Kan hypothyroidism kan macam rare sikit kan. So macam dalam Malaysia ada ke kes?
Banyak lah.
Macam mana?
So apparently memanglah dia kata rare, tapi this is actually it's not that rare actually. Because in general, if we talk about primary hypopituitarism, which is the genetic condition kan, because you know yang all the gene that you've mentioned tadi lah, porphyrin apa, or the PIT semua no, the PIT1 gene semua, these are rare. Okay, kalau primary hypopituitarism is rare, but secondary hypopit and in combination, I mean panhypopit is quite common. It's actually it's quite common lah. It's not that rare at all. At least in a month kita akan diagnose 1 or 2. Even even if medical tak diagnose pun, surgical will also diagnose just about the same number. Because some of these patients they presented to surgical, especially neurosurgical. Those with craniopharyngioma, SOD kan, septoptic dysplasia, biasanya pediatric lah, neonates. Tapi craniopharyngioma kan, biasanya they presented to the neurosurgeon rather than to us, to pediatric. But subsequently memang pediatric akan manage lah. Tapi sometimes we miss them. So actually bila sebut hypopituitarism ni, it is rare, but I don't think it's affected less than 200,000 individuals. I think this is some specific hypopituitarism, the primary hypopit. Tapi kalau we talk about panhypopit as results of something, for example TBI kan, traumatic brain injury, they can cause panhypopit. Apa lagi? Tumor, radiation surgery, radiation memang almost always cause hypopituitarism lah. So I don't think this is quite right lah, because at least I've got more than 10 kot patient kalau dekat USM lah. See all this kan, the total holoprosencephaly, we seen holoprosencephaly at least in a year, at least we've got 5 kot baby holoprosencephaly born. So itu dah 5, and I don't think it's less than 200,000. It's definitely more. Okay, ada soalan lain?
Okay, thank you.
Macam charge syndrome kan, usually at least per year kita dapat lah seorang charge syndrome. Actually ada satu, I got one patient here yang we are working for charge syndrome lah, because dia ada coloboma and then ada some dysmorphism. Cuma this child dia tak nampak dia endocrinopathy lah, tapi itulah possible, tapi I don't think discharge lah, cuma dia ada coloboma. And then holoprosencephaly, again at least in a year we've got 5. Septo-optic dysplasia, in a year kita orang akan diagnose. Kalau USM lah, waktu I kat USM at least 2 to 3 lah SOD. So it's not that rare sangat lah sebenarnya. Okay, lagi soalan? Actually, can we go through the slides lah? Because ada something yang macam tak betul sikit. Yunak kan? Yunak tau Yunak? Yang you sebut Unocoid. Apa you sebut tadi?
Unocoid tu.
It's Unocoid. Habitus. Yunak tau Yunak? Siapa tahu kata
Normal.
Ha?
Normal.
Tak, Yunak. Yunak ni apa Yunak? Siapa suka tengok cerita Cina zaman dulu tu? Macam cerita Cina yang zaman emperor tu.
Macam pembantu kan.
Yunak ni bahasa Melayu dia sida-sida tau. Sida-sida. Kalau baca translation dia sida-sida. Itulah Yunak. Yunak tu apa? Yunak ni orang yang tak ada sexual karakteristik. Faham? Biasa Yunak ni kita beri induce, kita potong lah dia punya testis, buang testis dia akan jadi Yunak lah. So Yunak ni basically dia male yang tak macam male. Dia ada body habitus macam female, and then dia punya gonads dia tak develop, itulah Yunak. Contoh the most common Yunak is actually Klinefelter lah. Klinefelter syndrome is one of the most common Yunak. Klinefelter, Fragile X, yang ni memang Yunak lah. So Yunak ni is usually because pituitary problem ataupun specific gonadotrophin punya problem. Okay, lagi. Go through the slides lah, kejap. So personally this is my interest lah. So maybe that's why I want to focus on this. But tapi there are few things yang you have to we should go through lah. Contoh macam start from beginning. Kita go through just laju slides. Okay. Bawa. Okay. It's very important to understand. Okay. Posterior pituitary did not synthesis hormone. They just secrete hormone. Oxytocin and DDH is actually produced by hypothalamus. Apa nama nuklei dia?
PVN and SON. Paraventricular. Paraventricular dengan supraoptic nuclei.
Okay, good. Supraoptic nuclei lah. Okay, lagi.
Hanya ada mistake sikit.
Okay, so kalau dia in general kan, this patient, okay, they will presented with deficient of the end hormone tau. Dia bukannya, dia tak datang dengan deficient of TSH, dia tak datang dengan deficient of growth hormone. Dia akan datang dengan deficient of the end hormone, which is hypothyroidism. So apa symptom of hypothyroidism?
Bradycardia, bradypnea,
No.
weight, hypothyroidism, weight gain.
Hypothyroidism. Short stature, weight gain macam tu kan. Constipation, developmental delay. Okay. And then kalau in your next apa sign symptom of hypothyroidism? Dia akan ada prolonged jaundice kan. So growth hormone deficient and also panhypopite and also hypothyroidism, one of the common presentation is prolonged jaundice. So you have to ask about prolonged jaundice. Okay. Okay, lepas tu kalau FSH deficient, so apa jadi? Dia delayed puberty, dia akan datang dengan delayed puberty. Ataupun dia akan datang dengan itulah micropenis in baby. Kalau in budak besar tak ada period. Kalau perempuan, kalau lelaki delayed puberty. And then ACTH dia datang dengan apa? Dia datang dengan hypoglycemia kan? Hyponatremia, hyperkalemia. So dia datang dengan cortisol deficient. And then prolactin memang dia tak datang lah in neonates. In pediatric dia datang bila besar, itu pun selalu tak datang pun. LH against dia tak ada menses, delayed puberty. So dia akan datang dengan the symptoms of end hormone deficient rather than symptoms of dia punya pituitary hormone deficient. Okay, next. Okay. Okay lah, the rest ni some specific disease. Okay lah tu cukup. Okay, ada soalan tak? Okay, ada soalan? Okay, kalau tak ada boleh next lah. Okay, next.
Assalamualaikum warahmatullahi wabarakatuh. I am Nur Atira binti Idris. Today I'll be presenting about hypothyroidism and hyperthyroidism. So the first one, we are going to take a look at the tak bergerak. Bergerak tak? Okay, so today I'll be presenting about hypothyroidism and hyperthyroidism. So first, we are going to take a look at the physiology of the thyroid gland itself to understand more about hypothyroidism and hyperthyroidism. So anatomically, the thyroid gland is located at the anterior aspect of the neck, where each lobe shaped as a pear. And then the apex is directed upward as far as the oblique line of the lamina of thyroid cartilage. And the base is located at the fourth or fifth tracheal ring. So this gland is well vascularized gland, and the arteries anastomose profusely over the surface of the gland. So the thyroid gland developed as early as the first trimester, where the gland descends from the floor of the primitive oral cavity, which is the foramen cecum of the tongue here, to its definitive position at the anterior lower neck. And during second trimester, the hypothalamic pituitary thyroid axis become functional. And later, peripheral metabolism of thyroid hormones matures at the third trimester. So a thyroid hormone regulation is a thyroid hormone is regulated by the hypothalamus pituitary thyroid axis, where it started from the hypothalamus. The hypothalamus will secrete TRH, which is the thyrotropin releasing hormone. So this hormone is released in a pulsatile manner, where it is stimulated by stimulus such as cold and stress. And then this thyroid hormone will bind to anterior pituitary cells. Anterior pituitary cells. Sorry. Okay, so then TRH will bind to anterior pituitary thyrotrope cell at the anterior pituitary hormone. This will stimulate the release of TSH. Then TSH will bind to thyroid follicular cells and stimulate the release of T4 and T3. So high level of T4 and T3 in the blood vessel will cause negative feedback to the hypothalamus and also anterior pituitary. So whenever there is disturbance in this hypothalamus pituitary thyroid axis, it will cause abnormalities such as hypothyroidism and hyperthyroidism. Next. So next is the effect of thyroid hormone to our body. So the most important effects is calorigenic action, where it increase in the consumption of oxygen, which leads to increase in metabolic rate. So whenever metabolic rate increase, it will cause increase in nitrogen excretion and increase in needs of vitamin. So in patients which have high levels of thyroid hormone, it can cause vitamin deficiency syndrome such as carotinemia, myxedema, abnormal menstrual cycle, and infertility. So for cardiovascular system, it can cause both direct and indirectly can cause increase in heart rate. So increase in heart rate and also cardiac contraction and also pulse pressure. For nervous system, reduction in thyroid hormone can cause slow mentation. And in children, it is very, very important for brain development, especially the cerebral cortex, basal ganglia, and also the cochlea. So that's why if patient or in children who have thyroid hormone deficiency during development, it can cause mental retardation, motor rigidity, and deaf mutism. For skeletal muscle, thyroid hormone can cause muscle pain or myopathy due to protein catabolism. And for carbohydrate metabolism, it will increase the absorption of carbohydrate in the gastrointestinal tract. And for cholesterol metabolism, it can help to lower down the circulating cholesterol by by increasing the LDL receptor on the liver. So this will cause more LDL to bind to the liver and metabolize and excreted by the liver. Lastly is growth. Thyroid hormone is very essential for growth and also skeletal maturation. In thyroid hormone deficiency children, bone growth is slow and the epiphyseal closure is delayed. And in absence of thyroid hormone, growth hormone is also depressed. This is because thyroid hormone can potentiate the action of growth hormone on tissue. Next, we move on to hypothyroidism. So hypothyroidism is a condition which the thyroid gland does not produce sufficient level of thyroid hormone. It can be divided into congenital hypothyroidism and acquired hypothyroidism. So, as its name suggests, congenital hypothyroidism is a deficiency or absence of thyroid hormone which present at birth. It occurs in approximately 1 in 2,200 to 3,000 neonates. So this is according to Malaysia National Congenital Hypothyroidism Screening Program. The etiology of congenital hypothyroidism is, the first one is mild descent of the thyroid and athyrosis. So it is the commonest cause of sporadic congenital hypothyroidism. And in early fetal life, the thyroid should be migrated from the foramen of cecum to the anterior aspect of the neck. However, if this failed to occur, then it will result in mild descent of the thyroid gland. While in athyrosis, it will cause absence of the thyroid gland. There is no formation of the thyroid gland, which leads to athyrosis. So these two can cause hypothyroidism. The second one is dyshormonogenesis, which is an inborn error of metabolism, where in 5 to 10% of patients, there is history of consanguineous marriage. And this genetic defect cause failure in synthesis of the thyroid hormone, which can include due to deficiency of thyroid enzyme, inability to concentrate, or ineffective binding. And the third one is hypothyroidism due to TSH deficiency. So the isolated cases of TSH deficiency is usually rare. However, it usually caused, the hypothyroidism usually caused by, as Aisha mentioned before, the panhypopituitarism. So this patient usually manifests with the manifestation usually together with other hormone, which is growth hormone, gonadotropin, and ACTH deficiency. So the fourth one is iodine deficiency. So it is the commonest cause of congenital hypothyroidism worldwide, and usually at the mountainous areas such as Himalayas and Andes. However, it now is less frequent because of the widespread supplementation of iodinated salt. Now it is a clinical manifestation of the congenital hypothyroidism. So the clinical manifestation of CH is in the immediate newborn period, usually are subtle. So you can't really see if this newborn have hypothyroidism or not. However, when weeks and months goes by, the manifestation become more evident. And by this time, if by this time, if you were to diagnose it by this time, and also the treatment start late, then it will mostly affect the development of the patient, of the newborn, of the infant. So this can cause various manifestation such as poor feeding, sleeps a lot, coarse facial feature, thick protruding tongue, prolonged jaundice, cold and pale skin, poor muscle tone, swollen protruding belly, belly button, constipation, and decreased activity. Now, for acquired hypothyroidism, it is hypothyroidism in older children. So the commonest cause of acquired hypothyroidism is lymphocytic or autoimmune thyroiditis, which is Hashimoto thyroid, or also known as Hashimoto thyroiditis. In contrast to untreated congenital hypothyroidism, acquired hypothyroidism is not a cause of permanent developmental delay. Hashimoto thyroiditis is a common cause of goiter, and a family history of thyroid disease is present in 25 to 35% of patients. Hashimoto thyroiditis is also is an autoimmune disease. So this is caused by immune response that attack the autoantigens, or in some patients when there is autoantibodies that attack the normal thyroid cells. So the inciting event that lead to this immunologic response is not clear. However, there are few mechanisms that can lead to this Hashimoto thyroiditis, which is the first one is CD8 cytotoxic T cell killing or cell-mediated killing, which can damage the cell and cause death to the cells. And the second one is by CD4 T helper cell, which release interferon gamma, they will recruit and activate more macrophage, which leads to thyrocyte injury. And the third one is by anti-thyroid antibody, which will attack the thyroid cells and leads to cell death. So this mechanism can cause lymphocytic infiltration and also fibrosis of the thyroid gland, leading to hypothyroidism. So the clinical manifestation of the onset of clinical manifestation for acquired hypothyroidism typically occurs after 6 years of age, with peak incidence in adolescent and with a female predominance. For sign and symptom, it can be diverse and include short stature or poor growth, cold intolerance, dry skin, cold peripheries, bradycardia, thin dry hair, pale puffy eyes with loss of eyebrows, constipation, obesity, and poor concentration. Now we are finished with hypothyroidism. Now we take a look at the hyperthyroidism. So it refers to overactivity of the thyroid gland, which leads to excessive release of thyroid hormone and consequently accelerated metabolism in the peripheral tissue. So most children with hyperthyroidism have grave disease. It accounts more than 95% of childhood cases of hyperthyroidism in the United States. So this is due to circulating autoantibodies, mainly by thyroid stimulating immunoglobulin. For grave disease, there are many manifestations of grave disease. It is which caused by autoantibodies against the TSH receptor. So mainly in grave disease, it relates to the TSH receptor, which by the autoantibodies mimic the action of TSH and bind to TSH receptor. For example, the thyroid stimulating immunoglobulin. So it mimics the TSH and bind to its TSH receptor and cause increased release of thyroid hormone. The second one is thyroid growth stimulating immunoglobulin. So it also mimic the action, but it did not cause increase in thyroid hormone, but it caused proliferation of the thyroid follicular epithelium or the thyroid follicular cells. And lastly, in contrast to the other two autoantibodies, this TSH binding inhibitor immunoglobulin will will prevent the TSH from bind to the TSH receptor. So it also can inhibit the thyroid cell function. This is why in patients with grave disease, they can also present with episodes of hypothyroidism. For clinical manifestation, grave disease are more common in girls than in boys, and with peak incidence in adolescents. So personality changes, mood instability, and poor school performance are common initial problem in grave disease. However, tremor, anxiety, inability to concentrate, and weight loss might be insidious and can be confused with psychological disorder until the thyroid function test reveal that there is elevated serum free T4 level. Other manifestations include increased appetite, sweating, diarrhea, rapid growth in height, advanced bone maturity, tachycardia, warm vasodilated peripheries, psychosis, goiter, and eye signs. However, eye signs are quite uncommon in children. So for investigation, we do thyroid function test. For the routine laboratory test, we measure the TSH. So it used third generation assay, which is able to distinguish hyperthyroid patient with a higher degree of certainty. It is used for screening and detection of subclinical hypo and hyperthyroidism. Next is measurement of total hormones. It measures the concentration of both bound and free thyroid hormone. However, it is affected by the levels of binding protein. So that in condition where serum binding protein is altered, total thyroid hormone no longer reflect free thyroid hormone concentration. That is why we frequently use the measurement of free hormones, because it is the biologically active fraction of thyroid hormone and physiologically relevant parameter and more accurate to indicate thyroid function. This is because the levels are not affected by changes in binding proteins. Next is the newborn screening for congenital hypothyroidism. So it is one of the major achievements in preventive medicine. And most neonates born with congenital hypothyroidism have normal appearance and no detectable physical signs. Hypothyroidism in newborn period is always overlooked, and delayed diagnosis and replacement therapy can cause severe outcome, the most severe outcome, which is the mental retardation. That is why it is very, very important to start the treatment and also diagnose early for congenital hypothyroidism, because if we start early, the severe outcome can be prevented. So this is the algorithm for management of congenital hypothyroidism. So we measure the cord TSH test, and if the cord TSH level is high, we will do reconfirmation test, which measure the venous TSH and free T4. So if the free T4 is still low, and immediately the treatment for congenital hypothyroidism is started. So for additional tests to diagnose and confirm other thyroid disease, for Hashimoto thyroiditis, we do serum antithyroid peroxidase, where nearly all patients of Hashimoto thyroiditis have high serum concentration of antithyroid peroxidase. And the second one is serum antithyroglobulin antibodies. It is usually associated with autoimmune thyroiditis, but it is not specifically for Hashimoto thyroiditis. And for Graves' disease, we do thyroid stimulating immunoglobulin. And other tests such as antithyroid peroxidase and antithyroglobulin antibodies can also be done. So for the last part of the presentation, which is treatment. So for congenital hypothyroidism, we give replacement therapy with levothyroxine, which should begin immediately after diagnosis and within 2 weeks of life. The prognosis of normal intellectual development is excellent if the treatment starts early. And if the therapy is instituted after 6 months, when the signs and symptoms of severe hypothyroidism are present, the likelihood of normal intellectual function is markedly decreased. However, growth can still be improved even in late diagnosis. For acquired hypothyroidism, we will also give replacement therapy with levothyroxine, and this treatment with thyroid hormone is sufficient to normalize the TSH and also the free T4. And lastly, for hyperthyroidism, Graves' disease, there are 3 options of treatment, which is the first one is pharmacological, which is the methimazole and propylthiouracil. So both medications are equally effective. However, propylthiouracil is no longer a first-line therapy due to concern of severe liver injury and acute liver failure. So this medication should suppress the thyroid function to a normal level without the need to add thyroid hormone replacement to normalize the serum free T4, which means this medication will not make the patient become hypothyroidism until it needs more replacement therapy. So the second option is radioactive iodine. So this radioiodine is lower in exerting therapeutic effects, may require repeated dosing, and is likely to cause permanent hypothyroidism. However, hypothyroidism is the desired outcome because it is easier and also safer to treat hypothyroidism rather than continued hyperthyroidism. And this method of treatment is entering the mainstream of children and adolescents. So the third one is the third option is surgery. So for surgical treatment, it consists of partial or complete thyroidectomy. And the risks associated with thyroidectomy include the use of anesthesia and the possibility of the thyroid removal will be excessive, which cause hypothyroidism, or that it will be inadequate, resulting in persistent hypothyroidism. So that's all for my presentation. Thank you for listening.
Okay, good. Any questions, anyone? Any questions? Actually, the simple tips is if you want to be good in endocrinology, you have to be good in your physiology. Because if just read about physiology, then you can understand and can actually explain the pathology. Okay lah, tak ada soalan. Then next lah. Last one. Tak larat lah. Last one apa?
Recap.
This is very interesting. Okay, Syed. In fact, you will definitely see rickets in your life. Okay, yeah.
Can you see this slide?
Yes, we can see it.
Okay. Assalamualaikum. I am Fatin Balkis and I'll present about the rickets. So, first of all, before I define the rickets, I will define bone mineralization first. So, bone mineralization is the process of deposition of calcium and phosphate into the osteoid tissue for development of the bone. So, if there is a failure in bone calcification or mineralization, then this is what we call as rickets in pediatric patient. But for adults, it is called as osteomalacia. The etiology, first is nutritional rickets. It is more to risk factor instead of etiology. So the risk factor consists of decreased exposure to sunlight, maternal vitamin D deficiency, diets low in calcium, phosphate, and vitamin D, and strict vegan diets. For the intestinal malabsorption, rickets associated with the small bowel enteropathy, when the small bowel enteropathy is characterized by the inflammation of the small bowel enteropathy is characterized by the inflammation of the small intestine. Then this inflamed condition will lead to the loss of the microvilli structure, and this is why it can lead to intestinal malabsorption. For the cystic fibrosis, in cystic fibrosis, there is protein called cystic fibrosis transmembrane regulator, CFTR. CFTR responsible to control the movement of the water and salts in and out of the cell. So if there's an abnormality in CFTR, the pancreatic secretion will be thickened and it will block the duct of the pancreas, and it will lead to reducing the pancreatic enzyme, and then it will lead to intestinal malabsorption. Same as cholestatic liver disease, as we all know, cholestatic is the reducing of the bile flow due to obstructed duct or maybe impaired secretion by hepatocytes. It will lead to intestinal malabsorption too. So that is impaired metabolic conversion or activation of vitamin D. There's 4 factors that may be affected in physiological process of vitamin D. First is defect production of 25-hydroxy vitamin D associated in the chronic liver disease. And second is increase in metabolism of 25-hydroxy vitamin D in the long-term use of anticonvulsant. And third is defect production of 125-D-hydroxy vitamin D in chronic kidney disease, Fanconi syndrome, hereditary type 1 vitamin D resistant. And fourth is target organ resistant to 125-D-hydroxy vitamin D in hereditary type 2 vitamin D dependent. Oh, okay. Then we proceed to epidemiology of rickets. In US and Europe, rickets mostly occur in infants who have dark skin and receive no vitamin D supplementation. In Middle East, rickets occur when infants are not exposed to the sunlight. In Africa, it related more to diet. In Bangladesh, 8.7% of children had at least one clinical finding. 4% had deformities of the lower limb. 2.2% had elevated level of serum alkaline phosphatase, and 0.9% had radiological evidence of active rickets. In some places, nutritional rickets affected up to of childhood population. In Malaysia, the study revealed that the prevalence of vitamin D deficiency among 13 years old is high at 78.8%. In 2008, children aged 7 to 12 years old had a high prevalence of vitamin D deficiency at 35.3%. In 2013, half children aged 8 to 12 years old had vitamin D insufficiency. And the similar study also shown that the prevalence of vitamin D deficiency has a high population among the Indian and Malay ethnicity compared to the Chinese, measuring the sun exposure and level of skin pigmentation. Then we proceed to physiology. So first, 7-dehydrocholesterol will be converted to pre-vitamin D3 with the help of the UV light exposure. So pre-vitamin D3 will be isomerized to the vitamin D3 or cholecalciferol. And cholecalciferol will undergo 2 steps of hydroxylation. First step in the liver. The enzyme of 25-hydroxylase that was produced in the liver will convert cholecalciferol to the 25-hydroxy vitamin D3. 25-hydroxy vitamin D3 is or has been known as calcidiol, is the good indicator of the vitamin D status due to its long half-life. Okay, then 25-hydroxy vitamin D3 will enter into circulation and go to the kidney. And in the kidney, second step of hydroxylation will occur in the position 1. So 1-alpha hydroxylase, an enzyme that was produced at the venal tubular cell of the nephron, will convert 25-hydroxy vitamin D3 to the 1,25-dehydroxy vitamin D3 or calcitriol. Calcitriol is an active form of the vitamin D. And calcitriol will act as the hormone, which it will promote absorption of calcium and phosphorus from the intestine. It will increase venal tubular absorption of calcium, and it will act on bone to release calcium and phosphate. And calcitriol also facilitates calcification, as I have defined before. And please note that parathyroid hormone is there to assist 1-alpha hydroxylase enzymatic activity. So parathyroid hormone responsible for the conversion of vitamin D and also increasing reabsorption of calcium from the intestine. But parathyroid hormone parathyroid hormone reduce the phosphate level of the parathyroid hormone reduce the reabsorption of the phosphate level, okay, from the kidney. And then the pathophysiology. Pathophysiology of the rickets simply arise due to decreasing availability of calcium and phosphate to mineralize skeletal matrix, and it will lead to growth plate expansion, bone weakening, and skeletal deformities. So we proceed to clinical manifestation. First, we have craniotabes. Craniotabes is the thinning and softening of the bone, especially after we elicit the pressure at the occipital or posterior parietal bones. And then rachitic rosary. Rachitic rosary is the bead-like appearance at the anterior rib ends due to expansion of the costochondral junction. Third is the widening of the wrists and ankles. Fourth is Harrison sulcus due to weakened ribs that were pulled by the muscle that lead to groove at the lower end of the rib cage. And fifth is the genoverum, bowing of the legs, and frontal bossing of the skull. Other features is failure to thrive, delayed closure of the fontanelle, hypotonia, delayed dentition, and seizure. For the investigation, we take the blood test and we can see there's a low or normal serum calcium and low phosphate level. There's also low 25-hydroxy vitamin D. It indicates the vitamin D deficiency, and there's a high serum alkaline phosphatase and parathyroid hormone. Since parathyroid hormone is there to maintain the calcium homeostasis, so that is why calcium can be normal, but phosphate level can remain decreased. Okay, then of course, if it is related to the bone, so we do the X-ray of the wrist joint where we see the cupping, the cup-like appearance, and the fraying, which is not smooth surface of the metaphysis, and the widened epiphyseal plate. Then this is the summary of the biochemical features of the rickets and osteomalacia. Then lastly is the treatment and management. We can give the patient the oral vitamin D. For the patient with poor compliance, we can give single day dose, which we give in 1 day, but divided into 4 or 6 oral dose. But for the gradual method, we can give oral vitamin D daily for 2 to 3 months until healing is well established. Orthopedic correction can be done for severe bone deformities. And other management is, of course, UV light exposure and also dietary supply of calcium and phosphorus. I think that is all from me. This is my references. Thank you. Is there any questions?
Okay, good. Diam. Tekan pause. Okay, diamlah. Okay, okay, so any questions? Rickets is very important, especially for you guys, medical student, because rickets can come in your exam. We've got a lot of rickets. So, what kind of children yang ada high risk of getting rickets? What are the risk factors of getting rickets? Vitamin D deficient lah. Because most common cause of rickets is actually vitamin D deficient. So rickets in general you can divide into hypocalcemic rickets or hypophosphatemic rickets. Okay, depends on the whether calcium or phosphate. Hypocalcemic rickets is usually due to vitamin D or we call diam boleh tak? Or what we call hypovitaminosis D. Okay, hypovitaminosis D. You know, in Malaysia, despite we are at the equator, kan, our vitamin D deficient is very high. Your data, I think there's a I'm not sure whether there's a typo or something, but according to study and our nationwide study on prevalence of vitamin D deficient, our vitamin D pathology can be divided into insufficient and also deficient based on the level. So our vitamin D insufficient is up to 70 lah, up to 70%. While our vitamin D deficient is about 10% or even less. About there lah, 10-20% macam tu. Still both we have to treat. Okay, sufficient we need treatment, deficient also need treatment, but different amount lah. So even though we are at the equator, most of our population are lack of vitamin D. Okay, especially what is the risk factor? You mentioned tadi, dua risk factor. Yang you kata American study is more common in because of
dark skin
and
sun exposure.
Yes, so the risk factor is dark skin and sun exposure. So being in the world where people are being more indoor and more sedentary lifestyle, so the prevalence of vitamin D and rickets is more common. So we are seeing more and more rickets now. So in general, we need a dark skin, a pigmented skin, macam orang Melayu or Indian. We need at least half an hour to 1 hour of sun exposure, good sun exposure per day. Okay, good sun exposure means the whole arm is exposed from the elbow to the tip of your finger, kan, and the leg is exposed. Okay, which is almost impossible lah. Exposed for at least half an hour. before 10 a.m. So exposed to sun before 10 a.m. for half an hour to 1 hour. So this is very difficult, especially among Muslim and also in general among all lah. Kita keluar matahari tak terbit and kita balik matahari terbenam kan. That's why we need supplements. Okay, definitely we need supplement. In European country, because they are lacking of sun, so most of the food are actually fortified with vitamin D. So they have lower vitamin D deficient level. Diam lah. Sekejap. Bismillah. Okay, okay, ada soalan nak pasal vitamin D deficient? Rickets is very common tau. You have to know rickets lah. You have to know rickets, and it's preventable. It's preventable. So you've got the genetic rickets. Most of the rickets is actually X-linked lah. You got X-linked dominant rickets. You got X-linked recessive rickets. These are hypophosphatemic rickets. So macam I mentioned tadi, dia ada hypocalcemic rickets. You ada hypophosphatemic rickets. Hypocalcemic rickets is usually due to vitamin D deficient, or we call nutritional rickets. And then hypophosphatemic rickets are mainly genetic disorder and also IEM lah. And the most common of them is actually X-linked hypophosphatemic rickets, which divide into two: X-linked recessive, X-linked dominant. Macam tu lah. So autosomal dominant and autosomal dominant and X-linked recessive. This is I don't think you need to know this lah. Tapi rickets is very important. You have to know the sign. Okay, bowing of the lower limb kan, bowing of tibia ataupun geniovarium. It depends on the age. Okay, kalau patient presented to you at the age of less than 1 year old, okay, biasanya dia akan ada, you rasa bowing dekat mana? Kalau baby umur 7 bulan, baby umur 9 bulan, where you should look for the bowing? Baby 7 bulan, bowing kat mana?
Pada legs.
Huh?
Dekat kaki.
No. Itu dekat tangan. Okay, you look for bowing dekat dia punya ulnar radius. Because dia crawling kan, So weight bearing on the upper limb. So dia akan ada bowing of the ulnar radius. Tapi if walking baby, then you can see the bowing dekat lower limb. Okay. And lactic rosary is very hard to it's rarely to be seen now. Okay, lactic rosary is quite severe rickets. Splaying of your epithelial can be easily seen. So patient with suspect rickets, you should look at the wrist. Okay, look at the wrist, look at the ankle. Okay, there's a widening of the wrist. Macam ni gambar ni. See, widening of the wrist. This is very prominent lah kalau dalam rickets. Bowing is very prominent also. Harrison sulcus is also one of the differential. And in adult, vitamin D deficient has been found to contribute to poor glucose control in diabetes, refractory hypertension in hypertensive patient. So because vitamin D has a large role, play a major role in your metabolism of your hormone, especially your sex hormone and your cholesterol hormone lah. And you tahu kalau perempuan estrogen kan cause vasodilation is protective for your hypertension kan. So patient with hypovitamin D, they've got problem with hypertension now. Kalau dia ada hypertension, it will be usually refractory, very difficult to treat. So kalau you ada parents ada DM ada hypertension, make sure you supplement them with vitamin D, especially women, okay? Because definitely our women are lacking of vitamin D. So do our women. Okay, ada soalan? Vitamin D physiology is very difficult, but it's very, 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 very important. Okay. So kalau contoh soalan tanya, okay, patient ni ada vitamin D deficient. So how do you supplement them? Okay, you have to be specific. You can cakap, we supplement them by cholecalciferol ataupun ergocalciferol, vitamin D1 lah. Kita tak bagi vitamin D3, except for patient yang ada kidney problem. Okay, patient ada kidney problem, kita bagi vitamin D3 ataupun cholecalcitriol. Because dia tak ada kidney tu to convert D2 to D3 kan. Okay. Tapi problem dia, this active form of vitamin D, dia tak half-life dia short. So you kena makan up to daily ataupun every few days. Compared dengan vitamin D1, D2 yang have very long half-life. Okay, any other questions? Dah maghrib lah. Last questions? Okay, tak ada Okay lah. Itulah tertanggung dengan tasbih kafarah. Dan syaratul as. Thank you for your time.
Thank you so much, Doctor.
Thank you, Doctor.
Thank you,
Doctor.
Doctor.
Yes, I go.
Thank you,
Thank you very much. Okay, bye.
Thank you, Doctor.